More than half of people with dementia right now have no idea that they have it. So today I'm excited to have on the show a colleague that I've been working with on research who spends her entire career helping people learn about their cognitive health. Dr. Shifali Singh is a professor at Harvard Medical School and a neuropsychologist by training. She also teaches about technology and mental health at Harvard. She runs the Digital Neuropsychology and Brain Health Lab at Mass General Brigham's McLean Hospital. And super thrilled to have her here today. Dr. Singh and I met through projects that we were leading in the grant program at Johns Hopkins to improve dementia care. Also, she's expecting a baby in a couple of weeks, so congratulations and thank you so much for doing the show before you go on maternity leave. And yeah, overall, I wanted to have this episode because Dr. Singh is working on making cognitive screening accessible to everyone through their phone, through their voice, and really simply by listening to the words they use every day. And I think that y'all will find it fascinating of what she's found along the way will change how you think about your own brain. If you don't know me, quick background, I'm Neal K. Shah. I'm a Johns Hopkins and NIH-funded caregiving researcher and a caregiver myself. So yeah, Dr. Singh, so glad you're here. Welcome to the show.
Thanks for having me. I'm really excited to be here.
Great, awesome. So kick it off. I had a few questions here, but one thing I think a lot of people may wonder is you're a neuropsychologist by training. And many people have not even heard that word. So, could you help us understand, what do you do in your work? How is it different from a neurologist? What kind of things are you mostly focusing on?
Yeah, thanks so much for asking that question. I feel like it's neuropsychologists aren't super great at marketing ourselves, and I think we do really important work. We can really understand how someone's brain is functioning at a really sort of basic but also granular level, and we do a series of sort of appointments with our patients, and we're kind of a very holistic profession in that, when I see a patient, I do an intake, and then we do full neuropsychological testing, which includes testing lots of different areas of your brain, like attention, memory, processing speed, executive functioning. And then, we synthesize sort of a lot of data and tell our patients how they're doing right now. And so we get a snapshot of how your brain is functioning. And it's a really unique field because a lot of people think, oh, an MRI tells me how my brain is functioning, right? But actually, we've found that MRIs don't tell the whole story. Sometimes people can have, I had one patient who went to a very sort of high-end clinic and got their brain imaged, and they were told that they only have 60% of their hippocampus. And so they came to me and they said, I definitely have dementia, but I don't feel like I have dementia. I feel okay. And so I tested them and I said, actually, you're doing just fine. And sometimes just your hippocampus size differs based on how your brain is sort of anatomically structured and organized. And so, I think a lot of people think, how do you measure your brain? Oh, I look at it, right? But actually, you test it. And we test our brains every single day when we ask, where were my keys again? Or where's my phone? Or how do I get to this place again? We test our brains constantly without even knowing it. And so we sort of have this very evidence-based, rigorous, sort of standardized method of evaluating cognition, which is nothing but the measure of how your brain is functioning. And we really understand that not just in the context of your brain in terms of its thinking ability, but also its mood. It's sort of your mood and your psychological presentation. And so what happens is someone might come to me and say, I think I have ADHD, or I think I have dementia because I have what I've heard so many times since the pandemic really is brain fog. And, they come to me and they say, I have brain fog, and I test them, but I also look at a very sort of extensive mood and psychological, profile, and I say, actually, you have really significant depression, and that's impacting your ability to attend and concentrate to things. You don't have dementia. And so what we do is really understand a very holistic, we get a really, really holistic view of someone's brain. So yeah, that's what neuropsychology is, and we get referrals from everybody: PCPs, nurse practitioners, neurologists. And so to answer your question about how we differ from neurologists, neurologists do an excellent job at managing a lot of chronic neurodegenerative diseases, but also other neurodevelopmental diseases, things like that. And they are more so on the medication side of things versus we use batteries of assessments and tools that have been sort of validated. And we actually have found that neuropsychological assessments are the most sensitive and specific to detecting cognitive impairment. More than imaging, we found that PET scans are only about 40% sensitive and specific to detecting things like Alzheimer's disease. Really, if you want to understand how your brain is functioning, you need a neuropsychological evaluation.
Thanks. No, thanks for sharing. I think that's like really helpful for people to better understand. I think the example that you gave, I think, was also really interesting and kind of a good case study in like the value of like neuropsychological testing and not just looking at brain imaging. I think in thinking about some of the work that you're focusing on, and I've heard you're even writing a book about this, but I guess before turning specifically into the topic of dementia, I think just would love to understand your thoughts around just like everyday thinking, just like what are I think some of the topics that you even teach classes about at Harvard around technology usage and how that affects people's thinking. Obviously, in today's age with the rise of social media and AI, a lot of people might be thinking about these topics no matter what age they are. So yeah, could you tell us a little bit more about that? Just like what insights have you found? What are you spending your time writing your book about? And just like what do you think would be helpful for most people to think about?
Yeah, thanks for asking. And at McLean in my private practice, Cambridge Neuropsychology, I see some very interesting cases where people are medically, have a lot of sort of complexity, but then psychologically there's a lot of complexity, like personality disorders, depression, anxiety, but trauma as well. And then we have really complex sort of cognitive profiles. And so we have to so when I'm sitting there, I'm looking through it kind of like, a detective trying to think through what's going on? What's causing what? And a lot of the sort of what I get, where I get the most information is really from just talking to my patient and understanding what sort of launched all of these things, right? And was it this fall that you had that catalyzed this dementia, right? Or was it something else? Was it because you were depressed for a really long time? And we know that things like depression and even more apathy, so like a lack of motivation, can be what we call prodromal signs of dementia, which are sort of early signs of dementia. And it's kind of like a chicken and the egg problem. And so a lot of this stuff to me sounds very inaccessible to the everyday person, right? And in fact, most people don't even know that you can measure your brain at all. And so I'm writing this book really to help people gain access to their brain in a way that we haven't been able to do before, really. And what I mean by that is giving tools for increasing what I call cognitive resilience. Because right now what we're doing is we're offloading a lot of our thoughts. We're using ChatGPT and we're using a lot of LLMs, which I think are wonderful tools. And I talk about that in my technology and mental health course. They can be fantastic tools and they can be exceptional for use in healthcare. And it can make our jobs a lot more efficient too. And I'm, as you know, I'm partnering with a lot of industry to kind of use AI to do those things. But as it relates to students and people in their everyday lives, so many of the decisions and the stimuli that we're given aren't chosen for us. So for example, when you go on, like let's say, Neal, you and I had our TikToks right next to each other, you would see things, I'm guessing, very different from what I see, right? And it's because the algorithm is so tailored to be addictive, right? It wants us to stay sort of hooked and connected. And with older adults in particular, social media use has rapidly risen to where sometimes someone might, as you get older, that activation energy to go outside and to take a walk, that might be reduced a lot, and instead you want to kind of stay on your phone and just play games. And I see it all the time, caregivers coming in and saying, he is always on his phone, she's doing her, math puzzles all day to like win tokens. Like there's a lot of gamification stuff that's happening, and specifically they're targeting older adults, and also my college students. Those are sort of really, really big buckets, and also very vulnerable populations, right? And so what I tell my college students is that regardless of your intention of going onto social media, the research demonstrates that you will be more depressed 2 weeks later than if you were to not be on social media. And how I think about it and how I explain it to my students is, if you think about how humans evolved, right? We were only meant to see just a small number of people in our tribes as we sort of traversed and walked through the fields or the desert or whatever it might be. And we were never meant to see ourselves very much or hear ourselves very much. And so social comparison was kind of like, well, there's me and this person that's around my age, and that's it, right? Now we're inundated with stimuli. And it's really taken a sort of a cognitive, it's been very cognitively draining, right? Because you can go on TikTok first thing in the morning and cry or laugh or be triggered by a traumatic event, right? And you're not asking for all of that emotional intensity, but it's giving you that. And so you don't really have control over what you're faced with. And so cognitively, that's really taxing for people, because it's like, instead of just getting up, getting out of bed, making my coffee, going to work, I've actually experienced 12 emotions before 8 a.m. And that's a lot, and especially for older adults. And again, my college students, when you're waking up first thing in the morning, that's when our cognitive clarity can tend to be the highest, right? And so that actually reduces activation energy, increasing risk of depression, increasing risk of things like dementia, because we know mood disorders can actually predict or contribute to the acceleration of cognitive decline. And so if I'm less motivated to brush my teeth, I might be less motivated to get out of bed at all, and then I might not exercise my brain, and then I may not use it at all, and then I might go on and have memory problems because I'm not using my brain. And it's not our fault. It's the environment that we live in. And so that's what my book is really about, is how do we live with our brains and think for ourselves in this world that kind of wants to think for us.
I think, first of all, thanks for explaining all that in great detail. I think that's absolutely fascinating, and I think anyone can relate to that. Like, I didn't realize, like, I hadn't thought about it in like such a research-backed way, but I think just very informally over the last few years, I've stopped really checking my phone in the morning besides using the alarm. But for the first like hour or so, I try not to check it because of all these things that you mentioned. I hadn't been able to articulate that, but between checking emails, because like I have a lot of work, and so something is always going on, and checking social media or checking news, all of these are factors that could influence how you even start the day and have emotional influence. And some of these almost purposefully, right, between the news and social media, they're going to try to create like emotional, agitation or whatever, if like, oh, this thing sucks, oh, this tragedy happened or whatever. And you don't want to like start your day thinking about that. So that's really interesting that I think that, I'm really excited, that you're teaching that and that you're kind of right about it, because I think that's something that many people in their day-to-day lives may not even think about. That's subconsciously happening to them.
Yeah, and exactly. And I'll add, what really preempted this were two things. One of them was a student who raised her hand, such a bright student, and she said, what's the point of going to graduate school if AI can think better than I can, right? And then another one that was recently, this past spring, and it was in my myth-busting pseudoscience course, so not even technology and mental health, but someone raised their hand and they said, do you think that our generation is going to get dementia earlier than any other generation because we don't use our brains as much? And then I asked the class, I said, can you raise your hands and tell me how many of you feel that way? Every single student, 60 students, raised their hand, and they expressed real concern that their generation is going to develop dementia at rates that we've never seen before. And it's kind of takes you aback, right, to think, about that and what it means for future generations. And as someone with a 14-month-old, I think about her generation. And I know you have small kids too, so we have like generation Alpha and Beta probably, right?
Yeah.
And they're saying that they're going to be the most depressed generation ever, and they're not even 1 or 2 years old. And so. And that kind of thing can really accelerate cognitive decline as well. I think we don't often talk about how mood symptoms and psychological symptoms can impact our thinking abilities. I think we kind of think of them as separate things. Like cognition is this sort of like biological thing, and mood is this psychological thing. But that's not it at all. And that's why I love my field so much. We really kind of look at everything and say, there are reciprocal relationships. And sometimes like people say, I have ADHD, but then I find actually there's depression there, but it's taking up so much of your cognitive load that there's no room for you to be able to attend to this task or finish chores that you have at home or do your assignment or even for older adults, go visit your grandkids or be able to have, some of them have word finding issues, and it's like, you don't have dementia. Actually, there's this issue. And so I think that's why I think evaluations are really interesting, because they can tell you sort of where your strengths and weaknesses lie and how to like sort of function within those spaces.
No, thanks for sharing that. And I think maybe just to kind of emphasize one of the things you said, I guess, could you repeat, to understand the point, are you basically saying that if you become kind of more pessimistic or negative in mood, that can accelerate, your probability of cognitive decline? I think that's like a fascinating point.
And I think that and they find, again, there are things that are prodromal signs of depression, and it's kind of a chicken and egg problem. So sometimes what we see is one of the biggest things that are impacted when you have dementia are circadian rhythms. People actually don't know this. Many people don't know this, but do you know what the number one reason people send their parents to a nursing home is when they have dementia?
No.
It's their sleep. It's not the memory problems. It's not getting lost. It's not, sometimes it can be a lot of things combined typically, but the number one reason is sleep. Their circadian rhythms change, and that affects your cognition even more. And that can affect your mood. And so, and then being depressed more can keep you at home more, can further change your circadian rhythm. So it's all really synergistic. And that's why our conceptualization of what Alzheimer's is has fundamentally changed. Before we used to thought it was amyloid and tau proteins, right? But now we find that sometimes amyloid is, buildup is in people that are totally cognitively fine. So how do you explain that, right? Yeah. And so that's why, maybe transitioning to some of the research we're doing, that's why I think it's so interesting, because I'd rather you compare, I compare one person to themselves rather than one person that's having similar symptoms, because the cause of those symptoms can be so vastly different.
Yeah, no, that's super helpful. And thanks for sharing. And I think, thinking about, talking about the research, and I think maybe talking to kind of like why you do some of the research you do, I think maybe that's like a good setup, of like, I think that you have mentioned, and, I think some of the statistics out there about like, more than half the people who have dementia may not even know it. I think that we observed in settings like in rural America, there's almost like sometimes, depending on the area, double the rates of dementia. I live in North Carolina, which is like kind of an interesting state where some of it is big cities, like 2 big city areas, but then the vast majority of the state is pretty rural. And there's drastic differences in dementia rates and even just like health access. But I think that, what's going on with kind of like screening, like, is there a lack of options, in most of America? If you think you might have memory problems or memory loss, why don't people have access? And, I think then that, maybe sets up for like understanding what else can we do to improve the access.
Yeah, so that's a great question. And there is an access problem in neuropsychology. We are we have long wait times. Our tests are long. And one of my biggest complaints is that although they're incredible at detecting cognitive impairment, more than any other type of assessment that we have, they're a single time point of assessment. So let's say you didn't sleep very well, and you come in and you assess your cognition. You're not going to perform as well as if I caught you on your best day, right? And sometimes what people ignore is the difference between subjective and objective cognitive impairment. And what do I mean by that? Subjective means I think that there's something wrong with my brain. Objective means there is something or inefficiencies that we're quantifying using these tests that we'd like to that we've captured using these tests, right? And sometimes what happens is someone comes in and on testing they do great, but they say, but I don't feel great. There's something going on. I'm not performing the best. I know I'm better than this. I know I can do better. I'm forgetting things more than I used to, and I just feel inefficient. Well, how dismissive of me would that be to say, well, you're fine, right? And so that's why I do the research that I do, because I believe that cognition is something that we should measure every single day. We should be able to assess your brain health every single day. And I think that that's one area where technology is really exciting, because we're able to assess things like cognition and speech and mood and your actigraphy, using an Apple Watch or Fitbit or Oura Ring or some of our own actigraphy monitors that we have, and really understand everything about you. So what happens in the studies? In the studies that we do is we have people just saying we don't tell them to come in. We say go and live your everyday lives. And what we do is we send push notifications to their phones, and they're assigned digital cognitive tests, speech tests, mood tests. And what I mean by mood tests are just questionnaires about their mood and things like that. And they're tested with their memory and their attention, executive functioning, processing speed. And then the speech tests, I'll do a side tangent just for a minute to talk about why we're interested in speech, which I know you know because we're doing projects together on it, but it could be good context. Speech has been demonstrated to be an incredible proxy of cognition. And that makes sense, right? How someone speaks to me, I can understand sort of how well they're functioning cognitively, right? If they're slurring a lot, I might be concerned for some sort of speech impairment or even an aphasia, right? Or if they're talking, kind of like if their affect is really restricted, like they're not moving their face a lot, I might say maybe they're, having some depression. And so as a clinician, we're really trained to look at these things, but we're not looking at it objectively. It's our own subjectivity, and then there's bias also, right? And so what we found is that speech assessments alone can predict your cognitive functioning. And so what I would like to do, and what we're doing, is giving all these assessments to people, and they're ultra brief. Sometimes they're 1 to 2 minutes, and sometimes they can be up to 10 minutes. And we give them at different times of day, different days of week. And that way we can understand how someone's brain is functioning every day, all the time. Well, not all the time, some certain times of the day. And we can extrapolate a lot of interesting information. So that way, when you come and see me, I can say, well, yeah, you're doing fine on your cognitive tests and you look okay, but I noticed that there was a lot more variability in your attention over the last week. And actually, it correlated a lot with your sleep. And so why you're experiencing cognitive impairment is because on weekdays you're not getting you're not getting adequate rest, but on weekends your cognition is great. And so, I tested you on a Saturday morning, and so that's why you're looking great. But if I tested you on a Wednesday afternoon, you're spent. And I'm not getting the best cognitive ability there. And so that's really interesting, right? Because it's like I'm telling that person interesting data about themselves compared to themselves. And we think about longitudinal studies as being really scientifically robust because we can look at people over time, and they're considered really scientifically rigorous, but it's really hard to do. The nice thing about these types of studies where you're looking at multiple time points is that it's a longitudinal study. It's just within one person. And so if I track you over time, I can get insights. Just like when you wear an Oura Ring, you can see how your step count has changed or HRV has changed over time. And so when we think about it, though, in the context of dementia, that's where it gets really interesting. So there's a disorder called mild neurocognitive disorder, previously known as mild cognitive impairment, or MCI, as people call it. And a lot of people still call it MCI. It's just the diagnostic name nomenclature has changed a bit. And what is it? Well, it's this place that you're sitting in that isn't dementia, but it's not optimal functioning. It's kind of in between. And we find that about a third of people who we diagnose with mild neurocognitive disorder, because they have some inefficiencies in memory and attention and maybe some executive functioning difficulty, you know, they may have some difficulty, but they're still able to take care of themselves. And that's kind of the biggest difference between mild neurocognitive disorder, so this MCI, versus major neurocognitive disorder, which is essentially dementias, right? It could be Alzheimer's, vascular, frontotemporal, Lewy body, any kind of dementia would be under that major neurocognitive. So the biggest difference is, can they take care, can you function independently? Can you drive your car? Can you manage finances, medications, right? So, but we don't really know what predicts how, when, and I guess how fast someone is going to progress from mild to major neurocognitive disorder. So with mild neurocognitive disorder, you know, about a third will revert to baseline, about a third will stay the same, and about a third will progress to major neurocognitive disorder. Why is that? We don't know. We can guess. Mood and anxiety and psychological symptoms can certainly contribute. Genetics can contribute. Your exercising can contribute, can kind of stave off some of those symptoms. Not engaging in too much alcohol or substance use, things like that can help. And some of it is just out of our control, right? And so and most of the medications that we have target that specific group. So you've got to, so that's why the access problem comes in, right? Because you've got to access these people in an early enough stage where we can do something, because major neurocognitive disorder, unfortunately, we just don't have a ton of tools. And the tools that we have are really meant more for this sort of mild neurocognitive disorder range. And so it's a very important part to study, and what we're studying, because we're trying to understand what are all these factors that predict whether someone will revert to baseline or stay the same or progress. And so that is a gray area, and such an important, it's really important to have family or some support. And I say that because I know how many people don't have it, that I see every day, who are coming in alone and are isolated. And, you know, they often tend to come in later than someone that has a caregiver, because the caregiver is like, hey, I'm noticing some changes in you. And so that's why, to any older adult, what I say is, get active in your community, you know, talk to people. That is sort of the best thing you possibly can do. And that's what longitudinal studies like the Harvard study has shown too, is that it's actually social engagement that is the best sort of preserver of your cognition in your brain. Because it's very cognitively demanding to be social, right? To talk to someone, to understand nonverbals, to articulate ideas, to organize your thoughts, right? All of that's very cognitively demanding. So anyway, I know that was a lot, but hopefully that...
No, I think that was super helpful. Actually, I thought the most interesting thing out of the whole thing that I think might just be distillable and maybe even worth repeating, I think, for the audience in case they missed it, is that, and I'll phrase it in more, you know, layman's terms, but it sounds like a lot of people who think they have, you know, memory loss that is progressing are in like this pre-dementia phase, and you're saying only a third of them will go on to actually develop full-blown dementia, which is very uplifting in a way, because that means through choices you make and how quickly you can kind of change your lifestyle or just be proactive about it, 2/3 of people will escape that fate, you know, which I hope, you know, everyone can escape, because it is obviously a devastating disease for both the individual as well as their family. So I think that is very like, I think that's like worth repeating, at least because I think many people don't know that. You know, I think the unfortunate problem is that a lot of people I talk to who are caregivers or have had parents go through this or spouses, there's a almost sense of doom or like inevitability, you know, that people are like, okay, this memory loss is happening, that's it, you know, I'm screwed. And I think that the stats that you mentioned are cool, because it gives you more optimism, and I generally do believe like how you think about the world affects sometimes your life, but if 2 out of 3 people are not going to go into full-blown dementia, then that's like very, very positive, and I think worth everyone kind of paying attention to and thinking about.
Yeah, absolutely. And I think it can be a very difficult field, because, you know, there's just so much we don't know about what predicts how well or poorly someone might do in 6 months or a year. But I'll give another optimistic story. Is I saw a patient, and I just evaluated them for the 3rd time, And the first 2 evaluations, I diagnosed them with mild neurocognitive disorder. And they said, they were with their wives, and they said, what do I do? How do I prevent this from happening? After I explained sort of what happens. And I said, and I gave them all the recommendations: walking as much as you can, exercising, physician approved, obviously, safely, eating, and I gave them a link to an Amazon book that they immediately got, and it was about the mind diet, and Mediterranean diet, and making sure to have routine and structure, and the most important one, just like I said, joining some social groups. And so they did it. They did all of it, and they asked me something that I think is really important. A lot of people with MCI or mild neurocognitive disorder, they say, can I go travel? Like, how does this limit me? Can I live my life like I usually do? And for some people, the question is, more logistical, like, how do I drive? Like, can I drive? And we send them out to places where they can get tested for things like that. But can I travel with my family this summer? And I'm like, please go travel with your family this summer. That is going to be so engaging for you. Hang out with your grandchildren. That's going to be so protective for you and your brain. Talk to as many people as you can. Go do it. And I remember it was this particular patient who asked me that actually as well. And I remember like his face lighting up and saying like, oh, I can go to Spain? And I've been looking forward to this for like 2 years. And I was like, absolutely, you can go to Spain. And then I tested him the next year, and I said, guess what? I'm removing the mild neurocognitive disorder diagnosis.
Wow.
He reverted completely to baseline. And I said, I told you this could happen. And he was like, I can't believe it. And I'm still going to monitor him, every sort of like 12 to 18 months just to make sure we're tracking things. But he was fine. And I'm not saying that this will work for everybody. And I don't want, because I think that puts a lot of pressure on people that, well, I'm doing all the right things and it's still not working. And to that I say, it's not your fault. A lot of this is sort of that, variable that we can't control. And again, it comes with genetics and how old you are when symptoms start and all kinds of things. And after, 85, 1 in 3 people might have dementia, after a certain age. And so doing whatever you can, staying active, staying working as long as you can. I know that's a controversial one, but working does help, even if it's just volunteering. Just having somewhere to go can really help. And so yeah, there are some positive upsides that there can, with establishing routine and engaging in all these like sort of brain healthy activities. But people always ask me like, should I do brain games and things like that? I say they can't hurt, but there's not a ton of evidence that they, really strengthen certain cognitive functions. It's more that you get better at doing the game than your general cognition is sort of benefited. What I would prefer is that you go call up a friend and have a 2-hour long, sit at a cafe and have a conversation. That I think is some of the best medicine that we have.
That's awesome. And thanks for sharing. I philosophically am completely on board. Like, I think that if somebody, catches signs of memory loss and it's early in MCI, I love this story because it's not about expensive things. It's not about drugs. It's basically about volunteering in your community, join a group of people, spend time with your grandkids. I kind of generally love things like that because 1, they're just positive in the world. And then 2, there's no harm, like as opposed to if you take a drug or something. So no side effects and makes the world better. So that's awesome. And I also just love the story because it's like, that's a real example, and I think many people may not even realize that examples like that are happening. And it gives you kind of like, it takes the doom out of it, that there are different trajectories that it can go down. So yeah, thanks so much for sharing. I think, in thinking through, I think, some of the stuff that, we're talking about, in terms of how do you test. So I think people would love to hear, how can you, tell what's going on with your cognition through, voice, through how people speak, et cetera. So like maybe in a very, simpler way, like I think there are tests out there, that, are showing that, okay, if you ask people to describe a picture or, name as many fruits or vegetables that they can for 1 minute, some of these things can predict cognitive decline with like a reasonable amount of accuracy. Like, I guess, could you give some examples of like, what do these tests like pick up what are the takeaways for people out there who might be like worried about themselves? And I guess, what are kind of some of the benefits to running tests like this in terms of accessibility? And where do you hope this goes in the future?
Yeah, great questions. So what can we gather from speech is sort of like a blank space, honestly, because we have found that when we look at speech, there are certain characteristics that people have that can tell us whether they are depressed or anxious or even cognitively impaired. So I'll give you an example, and I don't want to give away too much of the test because I don't want to bias people in case they get tests, but say you have a picture and there's a ton of things going on in this picture. And their sort of output says, their verbal output when you're describing this is something like the water, it's black and white, or not so eliminating the water part, just saying like it's a black and white picture. That tells me that this person is not paying attention to the actual things going on, but actually that something more concrete, and that tells me a lot about how they're seeing the world, right? And typically those are called projective measures, which are not as scientifically rigorous, but can tell us some interesting qualitative data. You can think about it, not to get too in the weeds, but you can think about it like a Rorschach test, which I don't use because it's not necessarily evidence-based. But there's a lot of interesting, what we call qualitative data, which is something that you can't measure sort of with math, but you can measure it sort of based on sort of like a body of data from other people. So speech kind of melds the two, where you can get projective speech and you can get, you can understand how people are talking, but then you can measure really quantitative things about that. So for example, how fast someone's talking, the response time between words, the frequency of words, word variation. So sometimes what I see a lot in people with dementia is that they'll use sort of circumlocutory speech. And what that means is, okay, I'm supposed to name this object, and what is this? And it's like, you use it to write. It has, something in it that you have to refill sometimes, and I'm like, yeah, what is the name of it? And then I'll say, how about this? It starts with the sound pe, and they'll say pencil. And that tells me a lot, right? Because it's about, if I give them, sort of a cue, they're able to recall it a bit better, or sort of fish the word out, right? But on their own, they had a lot of difficulty. And so what might happen is that there's a lot of that sort of like circumventing in speech that we can capture, right? Where it's like, I can tell that they're thinking of words, but they're not using that word. And so speech becomes really long or over-inclusive, right? Because they're including every little thing that they can think of. And it's so interesting to watch. Some people would say, oh, that's really sad. But I'm also like, what a powerful tool the brain is, that it can reach into all these spaces and try to help you communicate in the way that you want to, despite not knowing exactly what to say. And I think that's the power and beauty of our brains, is that our brains, even if it feels like it's working against you, is always working for you. It's always trying to make new connections, even when we're 95. It's trying to learn new things, even if you feel like you don't want to learn new things, and that goes for any age. So I think that that's something that's really exciting about speech. And so where I hope to go in the future, I hope that we can send out requests to patients, and we're doing this in that A2 collective Johns Hopkins study actually was one of those. We captured all the data that I talked about before, and we're trying to understand what can speech capture so we don't have to do all these other things. Like what is, and so that way I can send a voice recording to a patient, and before I even see them, and I say, tell me about your day. And just by their speech alone, I'll be able to flag what sort of the severity of cognitive impairment, so I can get them in sooner, so I can see them. So that's the power of technology, is being able to assess people in real time, faster, and really, and it's very cheap,
Yeah.
And so that's the goal, is that hopefully just by talking, we can capture so much. And think about, I mean, people record themselves on social media all the time. People record themselves constantly nowadays. We have so much speech data. And so being able to do it in a research setting that's really kind of rigorous and protected in terms of HIPAA and security and all of that is really important, and something I think about a lot. But yeah, that's something that we have available, and that we have the tools to do it.
That's awesome. And I think that, yeah, to kind of add to your, your comments, like, I think what's also cool about the way that stuff can expand access is, like, in the part of the country where I live, like, for example, Duke Hospital is very close to us, but a lot of people who live in rural areas, if they're worried about their mom or dad or spouse, I've heard from so many people through, some of the doctors I know at Duke, that the patient will drive 3-4 hours, sometimes 5 hours to see the specialist, because near them there is no, I learned this recently, that something like 40-something% of America is in a neurology desert, where, like, there literally is no one around for an hour who can even give an assessment. So I think that, to your point, that's when people are catching it months or years later than they should, because the thought of scheduling an appointment 6 months out and driving your mom 4 hours to go see someone, that's like going to burn your whole day, or a couple of days even. And doing something like that, through talking, through a phone, or, a website or an app, I think is, like, pretty powerful, because it can help a lot of people just, like, quickly evaluate, if, like, hey, is there anything wrong, or maybe make a decision to go see someone. So yeah, I think that's super cool.
Yeah, and you think about people in poverty, for example, they're not going to have the resources necessarily to be, or the luxury or privilege to be able to take off that time from work,
Yeah.
right?
Yeah.
And so they have to work, and they don't have time necessarily to bring their mom or dad or grandparent 4 hours, right? And so wouldn't it be great if they could just use their smartphones? And we know increasingly, people always ask me, like, well, older adults, they're not using their smartphones. And I'm like, oh yes, they are. Like, they're really using their smartphones. They're relying on it. It's a lifeline for so many older adults. Even in rural communities, even in areas with lower socioeconomic status and access, that is what we're seeing. And so when you think about it as from an equity and accessibility perspective, that really drives a lot of what I'm interested in, because I'm like, well, why, if we can, they, like, people from lower socioeconomic statuses tend to get diagnosed later with things like dementia, and in a disorder that it's so important to capture people early.
Yeah.
That is really missing quite a bit, right, of an opportunity to be able to intervene and provide medication and medical intervention and follow up. So just being able to access people sooner could make so many people's lives just more enriching and fulfilling, and meaningful for longer.
Yeah, no, that's awesome. And in thinking about some of the stuff that, you've also talked about in terms of, study, like, thinking about the CareYaya, kind of like thinking about not just the person with the cognitive change, but also the caregiver. I guess, can you talk a little bit about that? Of, like, why does that matter? I mean, obviously, like, most of my work is around caregiving, but what do you see, in your field in terms of, like, to think about what's happening to the person with the cognitive change, to think about who is the caregiver, to think about what might be happening to the caregiver? What should the caregiver also be thinking about, not just for the person that they're caring for, but also for themselves? Why is it important to look at the pair together?
And I think we really connected on this during our first conversation, before, right when we started working together, because I was like, this is, the caregiver population is such an invisible population in some ways, right? We have the patients, we have all the studies on them, but caregivers have an incredible psychologically intense job, right? They're seeing someone who was previously their equal in so many different ways, sort of decline cognitively. And sometimes psychologically as well. In something like frontotemporal dementia, there can be a lot of impulsivity and disorganization and irritability. And so you might also see a lot of mood changes, right? And so not only are they navigating, the caregiver, not only are they navigating the loss of potentially their partner as they knew them, but also, their own aging process and how they're trying to, so it's just immensely cognitively challenging. I know that's why we're doing the projects that we are, to really understand what happens to the caregiver, right? And how can we intervene? And so something I'll say is that when we see caregivers that are the same age, or spouse, typically, that is typically what I see. Spouses and a lot of daughters. a lot of eldest daughters, and bringing in their parents, right, for these evaluations. And what I see a lot of, especially in the spouses, is this reckoning with, I'm getting older. How am I supposed to take care of myself and this person? But I want to take care of this person. I don't want to send them to a nursing home or an assisted living facility because that will change my life fundamentally, and I'm not used to living without them. And that is an incredibly challenging, very complex decision. And especially, without anybody else around and in a vacuum, they feel like this incredible sense of, this incredible need to step in and to take care of their spouse, just as they always have, but now with all of these sort of added on complexities. And so what I say is look inward and know your own limits too. And I think it's something that's really hard to do. And sometimes, we can point that out to our patients where, if I notice that, this person is undergoing, I had a case, someone was undergoing chemo, but their, partner had dementia. And I'm like, that is a lot to manage, to manage your appointments and theirs. And also they didn't feel cognitively, very equipped as well. So then what I did is I said, let's connect you with the geriatric case manager. Let's get you some more resources that are covered by insurance at home if possible. And then if needed, we might need to try an assisted living facility or something like that because it was just too taxing. And sometimes family members can help and sometimes they can't. And sometimes the caregivers and their spouses don't want the kids to help out because they don't want to burden their lives. And so it's radically complicated. And I think that there's no right solution, but there's certainly some things that we can do to assess internally or externally how someone's functioning at home and how well they're able to manage. But there does come to, and that's why I recommend reevaluation so we can ask those kinds of caregiving questions as well.
Yeah, no, I think thanks for sharing it. That sounds incredibly taxing of somebody going through chemo and caregiving for a spouse with dementia. And I think, through our work in caregiving, we just see, I think caregiving is like one of the hardest jobs in America. And just like it's not respected or talked about enough or supported at all, so I think that I'm glad you're, focusing on that too, because I think that's like critically important. And many of this research that we found also seems like the caregiver increases their own odds of cognitive decline because of the stress and the lack of sleep, so I think that addressing, cognitive impairment in the person who gets it has like a double benefit, especially if it's in like the earlier stages and it can be modified, has a double benefit, not just to their own health, but to reducing the caregiver strain. So I think, I think one thing a lot of people ask me also, but I think that they'd love to hear it from you, because I'm not this expert in this field, is that a lot of people are like, okay, I posted about, hey, there might be some projects going on that could help you catch it early. And I know you talked about this a little bit, but I just feel like worth asking the question again. If like many people say, hey, who cares if I catch it early? Many families would be like, I'm scared to test. I don't want the label. There's nothing you can do anyway. So like, do you kind of find what are the tangible benefits to, catching things early?
Yeah, that's a great question. And I get that response. Like, well, what are you going to do anyway? Am I going to come in for an infusion, every week or every month? And is it going to cause a brain bleed? Those are the questions I get all the time now. Shouldn't I just live out my life as I want without all these interventions? And the truth is that the interventions that we have right now that are the best ones, like being social, eating, exercising, eating right, exercising, exercising your brain, are things that are just good for you naturally. And so I think implementing stronger habits and healthier habits for your brain is going to just improve your mood and your quality of life. And by improving your mood, as we know, you can also, improve your brain health and your cognition, your thinking abilities. Because when we're depressed and sad, it is harder to think. That's true. So I think that is something that people can do. And I think when they come into the clinic, there's this incredible fear that I see in my patients' eyes where it's like, I don't want dementia. Please tell me I don't have dementia. And so I have to have a very kind of frank discussion with them saying that there is a possibility, but there's also a possibility that it's early and there's a possibility that it doesn't progress. And it's kind of, we have no idea how to predict how your brain is going to be within 1 to 2 years. We don't know. And so at least capturing this early can help you be aware of it. And then there are some medications like Aricept and Namenda that a neurologist might prescribe that has been demonstrated to be somewhat neuroprotective. And so there are medications that are most effective sort of in the earlier stages. And then there are obviously Lilly and Biogen have drugs as well, like Leqembi, and that can be used primarily for people with memory impairment and cognitive impairment, usually recommended for people in the mild neurocognitive range. And those are infusions, so they can be taxing as well. But getting in early allows us to monitor and track it over time. And how I think about it is like, it's one appointment. It'll tell you how you're functioning right now. But also, what I can do is tell patients about their strengths and weaknesses. So what I do is I say, you're actually really strong in this. And yeah, your memory isn't as great as it was, but instead of a grocery list, say a recipe. That's always what I tell people. Sometimes people do better when they're given context rather than list of words. And both things require memory, but one can be more taxing than the other. And so one example I give to a lot of my patients who have discrepancies within like a list learning test versus a story test is, I say, tell things like, to the spouse, I'll say, tell them that you're going to make pasta. And these are all the things that they need, right? And so that way when they go to the store, they're like, I can't remember what I needed. Oh yes, I'm making pasta. Okay, this is all the stuff that I need, right? And so those can be, it's not, helping a spouse or a person that you're caring for with dementia is not always like, I'll help you think of that thing, or I'll help you remember this thing. It's actually providing context and working with their cognitive strengths. And routine is also really helpful for that as well. Like sometimes what I'll say is keep a very strict schedule kind of on the fridge that they can come and see. So that way they're not disoriented. And sometimes what happens when people get disoriented, especially with cognitive impairment at any degree, is they can get agitated, right? Because they're previously so high functioning and doing all of these things, and now they notice that there's like, what am I supposed to do now? So if they can go to the fridge and kind of see, oh, it's 12 o'clock. Okay, lunch is in the fridge. They go and get their lunch. It makes them feel like they can have a bit more grounding in their day and more things that take up time versus like something like social media where they could just sit all day and do that. So, and I do see that. So those are things that can help quite a bit. So catching early, it gives an opportunity for some changes. And then let's say they do progress from a mild neurocognitive disorder to dementia. They've already learned that they have a routine. They already have learned how to do a lot of these compensatory things that they can carry on and will be internalized as they sort of might progress, but hopefully not.
That's super helpful and practical. So thanks for sharing that. I think, and then I have a bunch of rapid fire questions, that I think sometimes they're just good for sometimes if people don't want to watch the whole episode, they might just watch the short clips. But I guess before turning to that, anything important that I didn't ask that you think is worth asking about or knowing, for the audience?
Yeah, I think, there's a lot of concerns about being evaluated and how to get an evaluation. And I would just ask your primary care physician or your psychiatrist or neurologist or anyone that you see regularly for an evaluation to understand how your brain is functioning. And I think it's just good to have some sort of baseline, in terms of your cognition. I know a lot of people, a lot of neuropsychologists say the exact same thing where they're like, everyone should be evaluated. And I don't necessarily think everybody needs to be evaluated, but I do think that it's really helpful in understanding how your brain is functioning. So getting a referral can look something like that. And I have people in my private practice all the time, just like sending us messages just directly and saying like, I need to know how I'm doing without a referral too. So that's possible.
Yeah, no, thanks for sharing. I think that's super helpful. And I think a lot of people may not even know that like such a baseline, test exists. So I think regardless of whether or not, they have cognitive decline or not, makes sense to be tested, especially for people who might be worried about their own risk or who might have, kind of genetic or family risk. So I think that's super helpful. Okay, thanks. Okay, so now turning to a few rapid fire questions. These are just kind of like, interesting that people may be wondering about or that I've been asked by, people in the audience. But what's one brain health habit that everyone should start this week?
Going out with a friend, I would say. Grab coffee with a friend and spend as much time as you can talking about your day, about things that you're excited about, looking forward to, emotional things as well, like how you've been feeling. Don't keep it all in. Be able to, engage with people at a deeper level, and that's excellent for your brain.
That's awesome. Very practical and fun. So appreciate that. Then is forgetting names, a sign of dementia?
Gosh, yeah. So something I always try to understand is if this is a new thing or if this is something that existed their entire lives. Often with things like forgetting names, names of people, when I really dig in, oftentimes people are just like, you know what? I've actually never been good at names. And so to that, what I say is when you shake someone's hand, say, nice to meet you, X, and their name. So nice to meet you, Neal, right? And then it helps you kind of rote memorize it, internalize it, so you remember it better. Names of objects is a bit different. So if I used to be able to say, there's my phone, and I'm like, there's my thing that I text people with, right? Or I need to send a message on that thing. That's something to look out for. And likely, when I see dementia, it's more that other people are noticing it versus on the more mild side, people notice it themselves, if that makes sense. So usually if a caregiver is like, I'm noticing problems, but the person's like, I don't see any problems, that's often in the dementia more, and that's more of a heuristic. It's not a tried and true thing, but just something that I've noticed.
That's actually, that last part is fascinating,
Yeah.
So that's interesting because in the first part, it's almost like you're anxious about it, but if you're noticing it yourself, it's unlikely that you actually have, dementia.
And you
Or
could,
might be in
it just
earlier
might be
stages,
milder, or
Yeah.
like a mild neurocognitive impairment. So oftentimes, like when we notice things ourselves, that's like a good place to like go and get evaluated because likely things could be earlier on.
Yeah. Cool. That's helpful. Then what's the biggest myth about memory and aging?
Oh gosh, that everybody's memory declines as they age. In fact, what we find is that while you may have difficulty learning new things, the strategies that you use are better usually when you're older. So while your memory might not be exactly, it might be, there's plenty of people that do, and they're called super agers, whose memory just stayed perfect their entire lives, and that's great. But older people may sometimes learn things better than younger people because they're wiser and know sort of unique strategies for solving problems or approaching things, so that they may actually solve problems as fast as someone that's younger because they know how to use, executive functioning, and they've built up all these sort of cognitive strengths over their lives. So that would be my major thing, is you can totally learn new things.
That's awesome. I love that too, especially because I feel like a lot of the things about modern culture are so like youth obsessed, that there's like a myth that only young people can like learn fast and everything, especially with like over focus on technology. So I think that's awesome. Great. Yeah. Love that answer. What do you say to a family that is scared to get, their mom or dad tested because they may not want to know?
Yeah. I think it takes a lot of courage to get tested. I think people don't give themselves enough credit for doing that. And typically what happens is I get this question all the time. People come in the clinic and they say, I'm worried I'm going to get dementia because my mom got dementia. And I say, well, how old? The biggest question is, how old were they when they got dementia, right? Or you started noticing a memory decline. And they're like in their 80s. And I'm like, that is much less likely to be a genetic contributor. Now, if you said 55, 60, even 65, then I would say, well, maybe there is some sort of genetic marker there that's underlying. And different drugs have been shown to have different side effects based on the ApoE4 allele, whether they have double or single allele. So I think it's really important to get tested to understand how medications might work, your chances of brain bleeds with certain medications. So I think that's an important thing to realize, is that it's not that the information dooms you to anything, but rather helps inform treatment moving forward in a more nuanced way.
Great, that's helpful. Then, okay, now, what does your own brain health routine look like?
Working a lot. I like, so one thing I say to my college students is, you're doing the best possible things for your brain right now, except for, drinking and things like that. But like, you are, you're in a social environment, you're learning, you're trying new things, that is the like a beautiful place for your brain to grow. And it's also a very vulnerable time in our brain development, but that's a different story. And so my brain health routine is simply working and being able and eating well. And I make sure to go outside, get sun. Sun is not just important for vitamin D and like happiness, but it's also important for your circadian rhythm and reminding yourself that your brain, what time of day it is. And there's a lot of really interesting literature about just the sun, being in the sun and its effect on sort of your immune system. And actually, as an aside, we found that a lot of Alzheimer's disease, we're thinking now, could be also as a result of inflammation in the body. So doing things like yoga or Pilates or something that can stretch your body and so I love Pilates because it's like a cognitively demanding thing, but then also a movement demanding thing. And that can be really helpful because it trains your body and your brain to work together. So yeah, those are all the things I would say. And I take CoQ10, which is recommended. I take 400 mcgs and a day, and that's supposed to help. And people have variable sort of thoughts about fish oil. I take it, but with any supplement, I think that there's some caution that should be taken when approaching those. But in general, most of them, the answer is that it doesn't hurt, but it might not help. And so I think that that's just going into that with sort of that kind of cautious mindset can be helpful.
Nice. That's awesome. Cool. I think that's super helpful. And then last rapid fire one. If you could change one thing about how we diagnose dementia today, what would it be? And why, I guess?
I think we make a huge mistake in calling it one disease. Dementia is such a complicated term because it can include Alzheimer's disease, alcohol-related dementia, vascular dementia, frontotemporal dementia, Lewy body dementia, Parkinson's disease dementia, all kinds of other. It doesn't tell you anything about the etiology. Where is it coming from? And I think that has actually, we call it functional fixedness, when you see something in one way and you can't see it in a different way. And that's really what I try to do as a clinician. Is I say, don't let your own biases affect, or even if they're don't let your implicit biases based on what you've seen before tell you anything about the patient that's sitting in front of you, because you might miss something. And I think that we don't spend enough time thinking about where these problems have come from and what is contributing to them. I don't think we do a great job of thinking really deeply about those questions. I think we give a diagnosis and then try to use any treatment or intervention we can. But sometimes understanding where they come from and how the symptoms oscillate with those things. Like, let's say you've had sleep apnea all your life untreated, right? If you're not getting a sleep study and getting adequate sleep, your brain is going to continue to not function optimally, right? And so being more holistic and careful about how we give the diagnosis, I think, is really important.
Awesome. I totally agree. Thanks. I think, Shifali, I think this conversation has been a real treat. I think hopefully everyone's learned a lot of interesting stuff. I even have, even though we've worked together for a while. Thank you so much for sharing. And I think that, I really love the philosophy behind your work and the mission. I think it has potential to change a lot of lives, bring access to testing for a lot of people, and also just help people prevent the trajectory of going from mild impairment into full-blown dementia. And I also just like love the idea that, through conversations and hearing people's voice and how they describe things, and, even over, things like a phone call, or an app, that people might have access to something that requires sometimes specialists and living in big cities or months-long waiting time. So, I think overall this is awesome. I guess, yeah, please tell everyone, where can they find more about your work? What kind of stuff, projects you're working on, anything else about, even kind of like the stuff that you're teaching and the books you're writing. Yeah, where can they learn more?
So, and one thing I have to add, just clinically, I just thought of this, is, I mentioned that I like working a lot, to kind of maintain my cognition. And one thing I'll say is the vast majority of patients I see that notice cognitive decline is 1 to 2 years after retiring. And it's not because their brain has necessarily declined, but the routine has changed. And so you don't have to necessarily work every day. I don't think that that's necessary, and I think people deserve to take some time, of course, but establishing routine, that's why it can be so important, because if you don't have it, you can get really sort of cognitively exhausted if you're not using your brain in just somewhat of a similar capacity. And that's why the social piece comes in so much, because it's like, and if you fill your schedule with events and, meeting people and things like that, that is a wonderful way to spend retirement and protect your brain. So I thought I'd just add that.
Thank you for adding that, actually, and not to go on a tangent. I actually love that too, because I didn't say anything earlier when you kind of alluded to it, but I think now that you mentioned it in detail, I had like just a brief video that put out that, I'd heard that the most dangerous year of your life, in terms of mortality risk, is often the year after you retire. But I kind of like said that and like cited some stats, but I didn't understand the exact mechanism behind it. So that's really interesting that you're observing that in the clinic. That's shocking.
Yeah, it's like going from this thing where you're having to use your brain in the same way for 40, 50 years sometimes, and then not having to use it in that way. It doesn't mean that your brain is broken, but rather that you're having to adapt to your new life. And that it's almost like you're going to college again, right? Like but it's also ripe with opportunity to discover yourself in new ways, to go to an art class, to learn an instrument, to travel, to talk to people. So yeah, I would look at it as an opportunity rather than this, decline of something, of this function that you used to have.
So be intentional about planning what you do right after retirement, and don't just kind of sit on the couch
while you're working. You're like,
Yeah.
okay, like how do I want to spend this time? Because people sometimes they do it, and then the next day they don't go to work, and they're like, well, now what? And then that can cause a lot of depression. So, okay, where to find me? So, so I have Cambridge Neuropsychology, which is my private practice where I see most of my patients, and then I, of course, see our wonderful patients at McLean Hospital, which is part of the National Brigham system. And we see really medically and psychiatrically complicated cases and really try to make sense of them. And so it's wonderful, and all my colleagues are terrific there. And then, that's basically it. And, if you're an undergrad and you want to take my course, that's another place to find me. But
when's your book coming out?
What was that? Yeah. Well, and I'm working on it, and hopefully that will come out in the next couple of years. But I'm excited to share all the things that I've learned.
Cool. That's awesome. Great. No, thanks so much. And also congratulations on being a mom again soon. I hope, thanks so much for doing the show before you took off for maternity leave. So that's awesome. And I hope everyone in the audience really found the episode insightful and valuable. I mean, I certainly thought this was an awesome conversation. And, if this one hit home, do one thing today. If someone you love, a parent, a spouse, or even just like a friend, you think something feels off, don't just like wait around, ask specifically even their primary care doctor, just for seeing a neuropsychologist or having a cognitive evaluation, not just like a couple of quick memory questions, but a real one. We're going to be sharing clips from the conversation across all our platforms, Instagram, Facebook, YouTube, and others. So keep an eye out. If this makes you think of anyone that send it their way. Shifali, thank you again so much. I think this was a wonderful conversation, and thank you to everyone for spending time with us. Yeah, you asked great questions, so thanks so much for the conversation. I appreciate it. Cool, awesome. Thanks everyone, and we will see you on the next one.